All right. So hello, everyone, and welcome to our Project Echo series, highlighting subject matter experts and topics relevant to Region 8 disaster preparedness. Today, we're going to hear from Dr. Heather Young on a timely review of hantavirus symptoms, transmission risks, and treatment as we continue to address the outbreak initiating aboard the MV Hondius cruise ship. Before we begin, I'd like to just take a moment to orient any new attendees to the Project Echo platform. This platform aims to support case-based virtual learning that connects experts to public health officials, responders, and clinicians working in the field. This learning series was awarded to Denver Health by the Robert Wood Johnson Foundation via the Echo Institute and will be holding sessions twice a month through September 2026 on topics critical to disaster preparedness. We hope to reach our Region 8 audience in Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming to strengthen preparedness and response through shared learning. And we encourage open discussion in these sessions, so please feel free to raise hands, come off mute, or put any questions or anecdotes in the chat. And we hope through this shared discussion, utilizing the ECHO model, that we're successful in building professional knowledge and increasing access to expertise. A few quick disclosures before we begin. The grant is funded through the Administration for Strategic Preparedness and Response. The content is produced by the individual presenter and does not represent the official policy of the U.S. government. Additionally, this information is not meant to substitute for professional medical advice, diagnosis, or treatment. All right. And with that said, I'd like to introduce today's presenter, Dr. Heather Young. She's an infectious disease physician at Denver Health, serving a diverse socioeconomic and cultural community. She is also the medical director of infection prevention and principal investigator for the Region 8 Regional Emerging Special Pathogen Treatment Center, where she's participated in two activations for patients under investigation for special pathogens. Her research focuses on infection prevention across the care continuum, including early identification of infectious patients, protection of others in clinical settings, appropriate use of PPE, and implementation of evidence-based practices to prevent healthcare-associated infections. Heather, if you'd like to begin.
Thanks so much, and thanks everybody for joining us today. Right, so I'm going to share my screen here. Bear with me. All right, is everybody able to see that slide?
Yes. Yes, looks great.
All right, fabulous. So today we're going to talk about hantavirus. And as Katie mentioned, I have no disclosures, no financial disclosures, and no conflicts of interest. So there are four things I'd like to talk about today on our agenda. The first is to go over a detailed epidemiology study of the MV Hondius related Andes hantavirus outbreak. The second is to talk a little bit more globally about hantavirus clinical syndromes around the world. The third is to dive in a little bit more to the Andes hantavirus clinical syndrome. And then lastly, I'd like to speak a bit about the public health and medical responses, in particular for the Andes hantavirus. All right, so number one, the epidemiology of the MV Hondius related Andes hantavirus outbreak. It's a mouthful. All right, so I want you to take yourselves back to maybe 3 months to March of 2026. If you were planning to be a passenger on the MV Hondius, you were going to be congregating in Ushuaia, Argentina, which is at the southern tip down here, the southernmost tip of Argentina. The planned departure of this cruise was on April 1st of 2026. There were 114 passengers, 61 crew members, and 23 nationalities. And Ushuaia looks like a really beautiful area. I've never been down there, but it looks absolutely gorgeous. So it's on the coast, so a lot of sea to be had there, a lot of wildlife, also a lot of mountains, a lot of forests. Of course, in the southern hemisphere, October through March and April is their summer, right? And then May through September is their winter. So in February and March, and even into April, that's the high time for outdoor activities, such as going on cruises to Antarctica, as these people were doing, for visualizing wildlife and for doing all sorts of things that are outside. So I'm going to go over a little bit of a timeline of the MV Hondius hantavirus outbreak. So as we said, on April 1st, the ship departed from Ushuaia, Argentina. On April, well, there are some conflicting reports. It was either April 3rd or April 6th. The first passenger began to develop symptoms of hantavirus, and these were respiratory symptoms. And then on April 11th, this passenger passed away on board due to respiratory illness. Between April 13th and April 15th, the ship visited Tristan da Cunha, which is a remote island in the South Atlantic. 9 days later, the ship went to St. Helena, which is another island in the Atlantic, where this individual's body was removed from the ship. His wife was also ill at the time, and she was taken off of the ship at that time. She was later flown the next day to Johannesburg, South Africa, where she ended up passing away in a hospital nearby. 29 the ship at that point on April 24th in St. Helena. On May 2nd, there was a third death on board the ship, and the WHO was alerted that there was a cluster of severe respiratory illnesses that have now resulted in 3 deaths. On May 3rd, the ship started trying to dock and had attempted to dock in Cape Verde, but there were concerns, public health concerns, that made that not able to be done. On May 4th, testing of some of the individuals who had disembarked the ship and the second passenger, the Dutch woman who passed away, showed that this indeed was a hantavirus and that it was the Andes strain. And then between May 6th and 7th, the ship ended up going to Tenerife in the Canary Islands, where the Spanish king permitted other nations to be able to send airplanes as well as ships out to be able to evacuate their nationals from the ship and bring them back to their home countries. So this is looking at the timeline. Again, very similar information, but in a little bit more of a map form here. So you can see Ushuaia leading to Tristan da Cunha about 2 weeks later, about 9 days later, ending up in St. Helena. A stop in Ascension Island, which was not mentioned on the previous slide. Cape Verde, where it was attempted to dock, but it didn't happen, and then the Canary Islands after that. So I next wanted to go over a line listing of the cases that we've found of hantavirus thus far. So case 1 is considered probable because this individual was not tested for hantavirus. He was an adult male, Dutch, and as we said on the previous 2 slides, he did pass away. His symptoms were primarily respiratory, and he had traveled in Argentina, Chile, Uruguay for 3 months prior to boarding the ship. Again, he boarded the ship on April 1st. His symptom onset was between April 3rd and April 6th, and he passed away on April 11th. Patient 2 was his wife, an adult female who was Dutch as well, and she's also deceased. She had both GI symptoms and respiratory symptoms. And again, she had traveled in Argentina, Chile, and Uruguay with her husband before boarding the ship. She went ashore in St. Helena on April 24th, deteriorated on her flight to Johannesburg on April 25th, and then passed away on April 26th. Her diagnosis of hantavirus was confirmed by PCR testing. The third case was a British adult male who developed respiratory symptoms, and he was medically evacuated on Ascension Island on April 27th and then was hospitalized in Johannesburg, South Africa. Case 4 was also confirmed. This was an adult German female who passed away. This individual had fever and malaise and then pneumonia. Her symptom onset was on April 28th, and she passed away on the ship on May 2nd. Case 5 was also confirmed by PCR, an adult male who had fever, fatigue, myalgia, and respiratory symptoms. This was a member of the cruise ship crew. They developed symptoms on April 30th. They were proven to be PCR positive on May 6th, and then they were medically evacuated to the Netherlands on May 6th and are in stable condition. Case 6 is similar to case 5, was also a crew member. Their symptom onset was on April 27th. They were also PCR positive on May 6th and were medically evacuated to the Netherlands on May 7th and are in stable condition. Case 7 was a Swiss male. Their symptoms were not reported. They were on the cruise ship as a passenger. They disembarked St. Helena on April 22nd, flew to Switzerland, through South Africa and Qatar, and then had a symptom onset on May 1st. The last time that I checked, they were hospitalized in Switzerland, but were in stable condition. Case 8 was a British male who had primarily GI symptoms and fever. He disembarked Tristan da Cunha on April 14th, and onset of his symptoms were on April 28th. The ninth case was a French adult whose symptoms began on a flight to France on May 10th, and they're doing well in stable condition. Case 10 had inconclusive testing and then has tested negative. This is an American. They had respiratory symptoms, mild respiratory symptoms. And so they initially were placed into one of our biocontainment units in the United States and now are currently in quarantine. And then the last case was just diagnosed maybe about 10 days ago and confirmed by PCR. It's an adult in Canada who also was a passenger on the cruise ship. They're undergoing treatment in British Columbia and they're doing well in stable condition. And so this is an epidemiologic curve of the Andes hantavirus cases. You can see that our first case here, our probable case, the symptom onset here is listed as 4-3. 19 days later, his wife developed symptoms. 20 days later, another passenger developed symptoms, and then 21 days later, another passenger developed symptoms. And you're going to see this like 20 days-ish coming up a lot for hantavirus cases. The median incubation is right around 20 to 22 days. These cases, I didn't put in the dates for them because I actually wasn't sure if they were exposed to this individual or if they were exposed to these individuals. So it started getting a little bit messy when I started trying to calculate how many days after exposure these people might have developed symptoms. So I only calculated it for those first 3. Right. So let's leave the cruise ship for just a few minutes here. And just move to a global perspective of hantavirus clinical syndromes. So this slide I borrowed, and it was really made for Andes hantavirus, but it is pretty general for all types of hantavirus. And so I've made some modifications for you. Um, you know, Hantavirus infections almost always start with exposure to rodent excrement. The virus is found in rodent urine and feces, and then infection occurs when the excrement is inhaled in its dry and aerosolized form. So we'll see on the next slide that there's old world versus new world hantavirus, and those infections can have different symptoms, but fever and myalgias or muscle aches are similar in each of these hantavirus varieties. And the prevention of hantavirus is similar throughout all of the worldwide varieties. You want to avoid rodents and their excrement, and that's really most important. And as rodents are attracted to food, keeping your food sealed so that they can't access the food and then take up residence near your habitat is going to be most important. So finally, if you're going to clean up after some rodents that you find, you should wear a mask to protect yourself from inhaling the aerosolized excrement particles. There are dozens of hantavirus varieties throughout the world. Europe and Asia have the Old World varieties, which tend to cause a hemorrhagic fever and renal syndrome. The mortality associated with these hantavirus infections is about 1 to 15%. In contrast, North and South America have a different clinical syndrome. It's a cardiopulmonary syndrome, and the mortality associated with this is much higher, 25 to 50%. And on the subsequent slides, we'll talk about some of the most common types of hantavirus in the world and then their clinical characteristics. So the first one is the Pu'umala virus. So the Pu'umala virus is carried by the bank vole, who's this cute little guy here. And there are several thousand cases of Pu'umala virus diagnosed per year, as well as many that are thought to be subclinical that are never diagnosed because people don't present for healthcare. It's common in Scandinavia, Finland, Western Russia, and parts of Western Europe. And case fatality is less than 1%. It actually presents fairly similarly to a viral hemorrhagic fever, although fairly mild. So people can get fever, chills, myalgias, and headache. They can get GI symptoms such as nausea, vomiting, diarrhea, and abdominal pain. They can get blurred vision and glaucoma. They can also get low platelets or thrombocytopenia, petechia, which is a rash on the skin that's consistent with low platelets, hematuria, which is bleeding in the urine, proteinuria, which is protein spilling into the urine, and renal failure. And that is the definition of nephropathia epidemica, is this proteinuria and renal failure syndrome. The next hantavirus that we're going to talk about is this Hantan virus. So during the Korean War, around 3,200 cases of epidemic disease occurred from 1951 to 1954 among UN soldiers who were stationed near the Hantan River in northern South Korea. The disease initially received the name Korean hemorrhagic fever. Infected people experienced typical symptoms of hemorrhagic fever and renal syndrome, such as headaches, fever, chills, anorexia, and vomiting. The case fatality rate was initially about 10%, but dropped down to 5%. And because of how severe this was, the US military actually established a hemorrhagic fever center close to where most of these cases had occurred. And they were airlifting suspected cases to this hospital for treatment. In 1976, Ho Wang Lee, a Korean researcher, showed that antigens taken from the lungs of the striped field mice, who are these guys here, were reactive to antibodies from the serum of people who had this Korean hemorrhagic fever. And then the disease was later named Hantan virus after the Hantan River nearby. So again, first discovered in the 1960s. Excuse me, 9,000 to 12,000 cases per year. The majority of these happen in Eastern China, but also can happen in South Korea, Russia, and Vietnam. And the case fatality is around 6%. One interesting fun fact is that it can rarely affect the pituitary glands and cause empty sella syndrome. So this is your normal pituitary glands with some tissue in here. And then this is empty sella syndrome where the tissue is actually absent in that area. And so this would mean that the appropriate amount of hormone is not being produced by the pituitary gland. And so it requires some endocrinology supplements in order to produce to supplement the right hormones for bodily function. All right, so we're going to leave the old world and we are going to move into the new world to Sin Nombre virus. So we're going to move up in time to 1993 in Gallup, New Mexico, at which time we had a 19-year-old Navajo man, and he was traveling with his family, unfortunately, to his fiance's funeral. And he began struggling to breathe in the back seat of his family's car. His family pulled over and called 911, and he was rushed to the emergency department of the Indian Medical Center in Gallup. The young man didn't survive. He had massive pulmonary edema and didn't make it out of the emergency department. But he was not the only one. There was a young woman who had died of the same illness the week prior, and then there were more than a dozen young Navajo who died of the same syndrome in the following few weeks. And this was basically the beginning of the recognition of Sin Nombre virus. For those of you who might not be super familiar with New Mexico geography, I put up a map here. We have Gallup here. It's right on the edge of Navajo Nation and just a little bit north of the Zuni Reservation and just a little bit south of the Four Corners area, which is really the area that we think of now as being the hotspot for Sin Nombre virus. So as I said, also known as the Four Corners virus, also known as Convict Creek virus and the Muerto Canyon virus. Again, based on two geographic features, which were close to where the virus was initially recognized. The deer mouse is the vector. So you really need to know your rodents. And if you find a little critter who's running around, you need to really take a good look at it to figure out whether this guy is one of the ones that's known to carry hantavirus or is not known to carry hantavirus. So rats are not known to carry hantavirus. These guys tend to be big, 9 inches, 7 inches, 9 inches for a brown rat, 7 inches for a black rat. The house mouse is also not known to carry hantavirus. These little guys tend to be 3 or 4 inches, sometimes domesticated and bred as pets. Not in my home, unfortunately. They are unwelcome friends who enter my house. But they tend to be all one color with a little bit smaller eyes. The deer mouse is the one that we do worry about in terms of carrying hantavirus. Two tones, so like a brown gray with a white belly. So, when I was a kid, we used to read these books about the country mouse and the city mouse. And then I was like, is there really a difference between country mice and city mice? Well, in terms of hantavirus, there actually is a difference between country mice and city mice. And it really is the deer mouse that you need to worry about, the country mouse, who's the problem for hantavirus. All right, so a little bit more about Sin Nombre virus. The incubation is about 2 to 3 weeks, and people generally will have the onset of a high fever, myalgia, headache, fatigue, and GI symptoms. About 4 to 6 days later, they'll have the abrupt onset of shortness of breath and hypoxia. Some of the other findings when they present for medical care is that they'll have pulmonary edema, respiratory failure, kidney dysfunction, elevated hematocrit, leukocytosis, a left shift or neutrophilia, and low platelets or thrombocytopenia. The diagnosis can be made by a positive hantavirus, IgM, and or IgG, and testing is generally performed at the CDC. All right, so with that, we're going to move on to Andes virus. Hmm. So on September 22nd, 1996, a 41-year-old male became ill with fever, headache, and rapidly progressive respiratory failure. El Bolson is a rural town with a population of about 15,000 in Patagonia. He was quickly transferred to Bariloche, which is a larger city of about 80,000. That's about 150 kilometers north of El Bolson. So the physicians were familiar with hantavirus pulmonary syndrome from the reports of Sin Nombre virus. And so they sent serology testing and the diagnosis was confirmed. 20 days after his symptom onset, one of his doctors contracted pulmonary hantavirus. and passed away. 21 days after his symptoms onset, his 70-year-old mother developed symptoms of hantavirus. Hmm. The physician's spouse then became ill, the physician who passed away. 27 days after her husband's symptom onset, which ended up being 19 days after his death. So she decided to travel to Buenos Aires, which was actually a little bit more of a journey outside of Bariloche for medical care. Her physician in Buenos Aires spent an hour with her at this time without wearing any PPE and performed a venipuncture. 24 days after this encounter, the physician in Buenos Aires developed symptoms of hantavirus. This physician had not traveled outside of Buenos Aires and had had no contact with rodents in the prior 2 months before this illness. So in all, there were 18 cases of Andes virus diagnosed in this outbreak with clear person-to-person transmission, the most convincing of which was the physician's wife transmitting Andes virus to her physician in Buenos Aires. So this, again, was the very first time that we realized that any of the hantaviruses, this Andes virus in particular, could be transmitted from person to person. And this really is a unique characteristic of the Andes hantavirus. And we have another anecdote of this. There was an individual who developed symptoms of fever and malaise in November of 2018 in Epuyén, Argentina. And Epuyén is about a 40-minute drive from El Bolsón. However, he had been invited to a birthday party and he didn't want to let the host down, so he attended the event for about 90 minutes. 5 people seated close to the index patient reported having an onset of symptoms consistent with hantavirus between 17 and 24 days after the party. One of these patients died 16 days after the symptom onset, and his spouse, planned a wake for this individual, for her husband, and happens to be febrile at the time the wake was happening. The fever in hindsight ended up also being hantavirus. So she exposed an additional 10 people at the wake, and they became ill between 14 and 40 days after the wake. Other spreading events included being at the hospital. So approximately 82 healthcare workers were exposed to symptomatic patients. PPE was sparsely available at that time, and it was sparsely used. When it was available, it was an N95, goggles, and gown and gloves. And 3 healthcare workers developed hantavirus. So in all, there were 34 cases of hantavirus that was associated with this person-to-person outbreak, with a single introductory case from presumed rodent exposure. And transmission of this was halted by the quarantine of contacts during the incubation period. So let's take a little bit of a closer look at some of the clinical symptoms that were most common in the Andes hantavirus outbreaks. So fever was seen in 100% of patients. Headaches, myalgias, GI manifestations, and abdominal pain were all seen in more than half of the patients presenting for medical care. And then when they did present for medical care, abnormal liver function was seen in almost 100% of individuals, 97%. And compromised respiratory function was seen in 3/4 of patients at the time of presentation. We can also see that there was a fairly even gender distribution. The cases were approximately 60% female and 40% men. Most patients were between the ages of 18 and 64, and approximately 1/3 died, or 11 out of 34 patients. Over half of patients were considered to have severe disease. The median incubation of the Andes virus in this particular outbreak was 22 days, just as we're seeing in the cruise ship data. and close contact was implicated in most cases. And patients were contagious for a variety of days. So after symptom onset, they could be contagious for 1 day, 1 to 3 days, or an unknown number of days. When lab studies were sent, thrombocytopenia or low platelets was present in almost all patients, and elevated LDH was seen in all patients. Elevated AST was exceptionally common in 94% of patients, and a prolonged PTT was present in 88% of patients. Leukocytosis, neutrophilia, elevated ALT, and then elevated BUN and creatinine were present in about 50 to 70% of patients. And then delayed PT or a decreased PT index were present in only about 20% of patients. All right. So I want to now switch gears just a little bit and talk about the public health and medical responses. As I mentioned, the outbreak in Epuyen was ended when contacts of cases were quarantined from others during the incubation phase, and a similar strategy is being used with the MV Hondius cruise ship passengers. So 7 Americans disembarked the ship early at the St. Helena stop, and they're being monitored by public health in their home states under modified activity restrictions. There are about 30 individuals who shared a flight with someone known to have hantavirus. So that would have been a flight from Johannesburg or a flight through Europe with one of the passengers who had developed hantavirus later. Those are considered to be lower risk individuals. And then there are currently 18 individuals at the National Quarantine Unit in Omaha, Nebraska. So this is a photo from the website of the National Quarantine Unit. I've heard that they have high-speed internet, exercise equipment in every room, and excellent food, including nice, robust local Nebraska steaks. I've heard it's quite a nice place to stay at if you have to stay there. This is a blogger who posted this. I did black out his picture because I didn't ask him for permission, but it is freely available on the web. So for the patient experience, the staff will wear PPE when they enter the room, and the patients need to stay in their room. But they're, of course, welcome to walk around, eat normal food, dress the way that they want to, decorate their room the way that they want to. And there is a 20 patient capacity. So they each have their own individual rooms. So they all are quarantined from each other. But what happens if someone gets sick? Well, there is a network of special pathogen treatment centers that can help take care of individuals who do get ill from special pathogens. In particular, the blue dots here represent level 2 facilities. So these are treatment facilities who are contracted to care for at least one patient for the entire illness. And then the orange dots represent level 1 facilities. And these are treatment facilities that can care for a minimum of 2 patients for their entire illness. They also will serve as education resources for their region. So you can see that Nebraska is a level 1 facility, and they can care for up to 4 patients. Here in Denver, we are also a level 1 facility, and we can care for 2 patients. Minnesota has a level 1 facility. Texas has one. Spokane, Washington does, as well as Cedars-Sinai in California. So there are a number of different facilities where these individuals could potentially go to if they were to develop symptoms of hantavirus. So the next question is, how long will passengers remain in quarantine? So we know that the hantavirus can be contagious for at least, we know that individuals can develop hantavirus for up to 40 to 42 days after their exposure. So the current plan is for passengers to remain in the quarantine unit for at least 3 weeks and then start transitioning to their home states under modified activity restrictions for at least another 3 weeks. High-risk contacts, including healthcare workers, should refrain from returning to work or participating in activities that may expose others. And each of the state health departments will have a very specific guidance and will be in close contact with these individuals, monitoring them for symptoms, and then coordinating with these local treatment centers in case an individual reports that they have any symptoms that need to be evaluated. If an individual does need to be evaluated, the appropriate PPE for healthcare facilities to use is contact plus airborne precautions. So that would be an N95, face shields, gown gloves, and then an airborne isolation room. It is category A waste. Um, so this PPE can be used. You also can use higher level PPE if you're more comfortable in it. And this is our high risk infection team who's doing a recent drill in their high level PPE. Honestly, practicing for a hantavirus patient to come to us and even practicing ECMO in our unit. The care for hantavirus patients tends to be supportive care. Um, you want to be sparing with IV fluids. If fluid is administered, small boluses should be used. For example, 250 milliliter boluses followed by immediate reassessment. IV fluids should be stopped if the work of breathing increases, if oxygenation worsens, crackles appear, pulmonary edema increases, or if there's no hemodynamic response. Fluid resuscitation needs to be guided by perfusion and blood pressure, lactate urine output, and potentially bedside echocardiogram, and the patient response. The patients definitely should not be managed as undifferentiated sepsis with large volume fluid loading because this can really be detrimental to patients, causing additional pulmonary edema. If patients have persistent hypotension or shock, it's actually recommended to give vasopressors early, preferably norepinephrine or epinephrine. And then activating an ECMO network early if somebody is deteriorating further is also something that should be strongly considered. There's no proven antiviral or immune modulating treatment that's shown to be effective for hantavirus pulmonary syndrome. So the management is really supportive and should focus on early recognition, careful hemodynamic management, respiratory support, and access to ECMO when needed. The pharmacology treatments that are listed here could be considered as investigational. They should not be used as just routine clinical care and should be administered only within formal research protocols or appropriately authorized and monitored through emergency use frameworks. So I'll kind of finish up here with potentially some bright horizons. The last of the passengers from the MV Hondius were evacuated on 5/7, which is now 20 days ago. No new cases have been diagnosed for about 10 days. And so I find myself wondering, has the peak symptom onset already passed? And I find myself wondering if we are going to even diagnose more patients or if we've really passed our most likely window. And I'm pretty hopeful that the rest of the patients are going to do great. So we're certainly here if anybody needs some support, but I'm hopeful that everybody's going to do really wonderfully. So with that, I'll say thank you and I'll open it up for any questions.
Looks like we have a question in the chat from Patricia Faust. How is the cost of isolation at this level handled? Who pays?
Yeah, it's a really great question. Are you saying the cost of isolation in the quarantine unit, or are you asking about the cost of isolation if somebody were to be hospitalized for symptoms?
Looks like we're asking about both, either one.
Yeah, yeah. So I certainly can't speak to the cost of the quarantine unit. I do know that the CDC has a contract with the quarantine unit, and so I would think that those are federal. So my best guess would be that those are federal dollars that are paying for the quarantine unit to be used. Um, Certainly, if a patient has symptoms and requires assessment, with hantavirus, we would be billing insurance, first of all. But I know that all of that would not be covering all of the special management that has to happen here. So that is still a work in progress. It's a really great question.
Another question in the chat from Mustafa, which patients with hantavirus disease are a candidate for ECMO?
I'm sorry, say that again.
Which patients with hantavirus disease are a candidate for ECMO?
Oh, sure. Um, so, so those would be patients who are mechanically ventilated, but are still not able to oxygenate well, who are on pressors, but you're still not able to maintain adequate blood pressures. So they're still having cardiopulmonary failure, despite your maximal efforts, and that's when ECMO would be started.
And then another question just regarding logistics for the presentation, asking if the slides will be available to review outside. I can say we are recording this session, so it will be posted on our YouTube channel and shared through the Project Echo platform. Heather, I don't know if you have any other way or if you'd prefer to circulate those slides.
Yeah, I'll just leave it up to you and we could share them however you guys think that they're best.
Sounds good. I will go ahead and put our post-session survey in the chat and then also share our closing slide for today's session. Although if anyone still has any questions, we'd be happy to hear them as we reach the top of the hour. You can use the link in the chat or the QR code here to access our post-session survey. It's just some brief feedback, and then if you have any thoughts on future sessions you might find valuable. And then also just wanted to share that our next Project Echo session is next Thursday from 1 to 2 Mountain Time. We'll hear from Dr. Anuj Mehta regarding the 2024 Becton Dickinson bottle shortage and how it impacted hospitals and healthcare systems differently, and how he responded to a request for medical advice.